Hello, everybody, and welcome back to our symposium. This is Chris Amos. I'm here to kick off the open discussion part of this symposium, and for that, the idea is to make this an open period where people can ask questions where they haven't had a chance to. But I also want to introduce two additional panel members. So first, Dr. Bettina Beech is the Associate Provost for Strategic Initiatives and Population Health Research and Associate Dean for Research in the College of Medicine and Professor of Health Systems and Population Health Science at the University of Houston. That's quite a lot of titles to fill. She's used her interdisciplinary training and leadership skills in the effort to combat COVID-19 by developing contact tracing courses that trained over 15,000 students. She's also a site principal investigator of an NIH-funded grant to examine COVID-19 vaccine hesitancy and perspectives among African Americans and Latinos. And also Dr. Peter Hotez is joining us. He's a frequent commentator on CNN and all sorts of sites, and he's the Dean of National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at the Baylor College of Medicine. He's also the co-director of the Texas Children's Center for Vaccine Development and Texas Children's Hospital Endowed Chair of Tropical Pediatrics. Recently, as both a vaccine scientist and autism parent, he's led national efforts to defend vaccines and to serve as an ardent champion of vaccines going up against the national anti-vax threat. And he's written a very nice book about, why his daughter's autism wasn't caused by vaccines, which is a great read. In 2019, he received the award for leadership and advocacy for vaccines from the American Society of Tropical Medicine and Hygiene. And so I'll start the session by asking a couple of questions. So for Dr. Beech, as mentioned, you've been leading an NIH-funded study to examine attitudes and perceptions about vaccines and COVID-19 testing. And what do you think some of the changes have been in the last few months about attitudes towards vaccines and concerns about COVID-19? Would you like to comment on that, Dr. Beech? Oh, you're muted.
Thanks, Chris. Our study is part of the NIH-funded Texas SEAL Consortium, using community-engaged approaches to understand attitudes and perceptions about COVID-19 testing and vaccines among African American and Latino communities, and I add the plural. Obviously, these groups are not monoliths. Our study has documented substantial shifts in attitudes and perceptions that align with the national trends at the early, midpoint, and now hopefully latter stages of the COVID-19 pandemic. The originally high levels of skepticism and reluctance to be vaccinated have been substantially tempered. And that is despite continued concerns about potential long-term effects of the vaccine. So our participants are very high consumers of news articles, and they share their concerns about vaccine side effects, the degree of actual immunity conferred. We hear the news stories about Yankees team members and individuals that have had breakthrough cases, as well as those that have had antibody testing after being vaccinated to not find any antibodies. So this perceived need for continued mitigation strategies is really part of what we're hearing. Also, the home testing kits have been a subject of discussion in our focus groups, and concerns about the sensitivity and specificity and cost. They're about $130 to $150, and I've just seen the first national commercials recently for home testing kits. So that's on the minds of our participants as well.
Thank you. Yeah, one thing about this pandemic is it sort of goes from global to community and back to global again. So, following that, I think I'll ask Peter to comment about what you think has been happening, at the global level, and about vaccine hesitancy, and any comments about how you're striving to combat that.
Well, I think there's a few things happening. Clearly, we're doing better in vaccinating certain countries than others, and the United States is up at the top. But even the United States is not perfect, right? I mean, if we look at the northeast part of the country, New England states, Maine, New Hampshire, Massachusetts, New York, New Jersey, and a couple of other states in the West Coast, they're reaching Israel levels in terms of heading towards 70% single dose, 50, 60% two doses, where I think we can vaccinate our way out of the epidemic. But down here in this part of the country, the southern United States, we're at half that level. So that what's emerged is a pretty strong north-south disparity in vaccinations. And a lot of that seems to correlate very well with the conservative movement, which took on anti-vaccine activities starting about 5 or 6 years ago under this banner of health freedom, medical freedom. So that's a problem that needs to be addressed. And then globally, we've got an anti-vaccine movement that is accelerating. So we have this unprecedented politicization of vaccines, that being defiant of vaccines is part of your badge to be part of conservative movements. But then now the Center for Countering Digital Hate, and it's amazing we have to have something called the Center for Countering Digital Hate, now estimates of the 12 leading anti-vaccine websites, organizations, these are not grassroots organizations anymore. They're well organized, well funded. They monetize the internet. They have 58 million followers, according to the center. And because that's not complicated enough, now you've got the Russian government. So the Putin government, according to the US and British intelligence, has launched this whole program of what's being called weaponized health communication to destabilize democracies. So they use this as a wedge issue, piling on our internet with anti-vaccine messages. And they're also working to discredit US and European COVID-19 vaccines in favor of Sputnik V. So now you've got an anti-vaccine empire and I call it an empire, it's a triple-headed monster of political extremism on the far right, now mainstreaming across conservative groups, second, the 58 million followers on the dedicated non-governmental groups, and then the Russian government and other state actors. So this has created a lot of complexity, and it's translating not only in the US, but globally as well. And this is an argument I've had a number of years with a lot of the donor community and the US government and the United Nations. It was always seen as sort of walled off as a US phenomenon, or maybe a US, partly European phenomenon. And it's not. Now we're seeing in Africa and Latin America people using the same anti-vaccine language that's used here in the United States. So this is now affecting vaccine equity. So we have and my last statement is, globally now we're doing a good job vaccinating the Northern Hemisphere. The US, UK, Nordic countries, Western European countries doing pretty well, but it's coming at an expense. Now we're basically, for all practical purposes, not vaccinating Africa, barely vaccinating Latin America. And part of it is due to this global anti-vaccine movement. A bigger piece is that we just don't have the vaccines made available for Africa, Latin America, despite the best intentions of the COVAX sharing facility. And we're trying to address that with our low-cost recombinant protein vaccine that we've developed here at Baylor College of Medicine by myself and Mary Elena Batazzi, who co-head the Texas Children's Center for Vaccine Development. But I know I've said a lot in one long, breathless sentence, so let me stop there and
I'm just wondering,
unpack.
I was also hearing in Africa sort of disinformation about the AstraZeneca's risks being sort of amplified and leading to disinterest in vaccinations.
Well, that's absolutely right. So, I mean, and this is the modus operandi of the anti-vaccine movement. They take a piece of something and they blow it up, and they're exploitative. So, for instance, the rare event of the rare cerebral thrombotic event that you're seeing with both of the adenovirus vectored vaccines, with the AstraZeneca vaccine and the J&J vaccine. First of all, the Russians claim their Sputnik V doesn't do it. Well, it probably does. It's just that it's, they've been pushing it so aggressively in countries with no pharmacovigilance systems, you would never know. And then what's done is the anti-vaccine pieces then blow it up and, try to impress upon people. They try to make the statement, this is not a rare event. And then people lose confidence in the AstraZeneca and J&J vaccine. So it's very destructive. And the one thing I like to say now, people are losing their lives from COVID-19 in part because of the SARS coronavirus too, but in equal measure to defiance of social distancing and masks and now vaccines or succumbing to the disinformation campaign.
So along those lines, we're seeing the vaccines, many of them are very effective right now. I guess there's a concern about what might happen given so many people are being infected with respect to novel variants. I guess this goes to the other panelists as well, what should we be doing to monitor as effectively as possible to intervene if some novel variant that's resistant or extremely lethal or something comes along? Is there anything we could do to intervene earlier?
I'll just say, different vaccines seem to be more resilient to the variants of concern than others. So there's data now showing that the vaccines that induce the highest levels of virus neutralizing antibody, the Pfizer, BioNTech, and Moderna mRNA vaccines, seem to handle them pretty well. So they're still partially, with the B117 variant, they're completely protective, but against the B1351 or the P1 from Brazil, they are partially protective. The ones that seem to give lower virus neutralizing antibodies to begin with, some of the adenovirus vectored vaccine, they seem to be less effective at preventing the variants. And so the bottom line is probably all of them will need to be boosted. So if you've gotten 2 doses of the Pfizer or Moderna vaccine, anticipate a 3rd dose, or if you got a single dose J&J vaccine, anticipate a 2nd dose, and either later on in the year or in the new year. And what that booster will do is elevate your new virus neutralizing antibodies even further to make it more likely to be cross-protective, increase durability, and they'll be reconfigured to be more specific for some type of consensus variant, some combination of the amino acid substitution in the 501 position, the 484 position, the 452 position, which seems to be more or less the convergence of many of the variants. And then the question is, and that we're doing the same with our vaccine, then the question is, will that be good enough for long-term immunity, or will we need to boost on an annual basis? And the scientific community disagrees. Some of us feel that may be enough. Others are saying, no, we'll need an annual booster, and Pfizer's already preparing these combination COVID-19 and influenza vaccines for that possibility, but that one is less clear.
So another question is, one thing that we learned from this pandemic is the benefits of the local government. The county and city public health departments have played enormously important roles in trying to combat the spread of the virus and make sure people are safe. I would say, what we learned in Paris and in France is about the benefits of remodeling the cities to be better able to get around using bicycles and other mechanisms. But I just was wondering about what the panelists think about public attitudes about the importance of the public health system. Do you think they've been impacted in a positive or negative way? What do you think?
Well, there's a recent Harvard School of Public Health study. The findings were released through Robert Wood Johnson Foundation, showing a national poll about public perceptions regarding the public health system in the U.S. at the federal, state, and local levels. The public is certainly, on the positive side, much more familiar with public health and what the scope of the work of the public health system is. And they strongly support increasing federal funding to support the public health system. So that's all great. But unfortunately, the public trust in healthcare workers far exceeds the public health system. And so there's low levels of trust, unfortunately, showing in the polls for the Centers for Disease Control at about 50%, for state about 40%, and local about 41%, even lower for NIH and FDA. And I think Dr. Hotez's comments speak largely to some of this mistrust in the public health system. So we've got a long ways to go, but I was really thrilled to see these findings that the public is much more aware of what public health is and what the public health system does.
So there's one question in the chat I wanted to bring up. Someone had heard that acquaintances are not taking COVID vaccine due to lack of information, and they think that it's better to get COVID and take antiviral medications that are being used to treat the virus. You also hear this disinformation about getting the vaccine is going to impair your immune system. So the question is, do the antiviral medications cost more money, and can they be given without being admitted to the hospital? And actually, the not admitted to the hospital is a good point. Right now, it's an infusion, so you can't do that. But is there any hope in the future that some antivirals could be like Tamiflu or something like that don't require hospitalization? Any comments? Yeah, Peter.
Well, I'll just say, in general, with viral illness, the impact of antiviral drugs is seldom as dramatic as preventing them with a vaccine. And the problem with COVID-19 is we learned there's two phases of this illness. There's initial virus replication. And then if that's allowed to proceed, then there's a host inflammatory response. So if you're going to intervene with a therapeutic, it has to be really early, like a monoclonal antibody, for instance, which you unfortunately have to give by intravenous infusion. So a combination of the fact that you have to give it so early in the course of the illness to have any impact, and then you have to have an infusion center, means it's, at least for now, these first generation therapeutics are going to be sort of boutique-y, not really applicable for a large population. So there's no substitute for vaccinating. And remember, there's a disinformation campaign about these vaccines, that they cause infertility, which is wrong, or they cause they modify your DNA, which is wrong, or and it gets crazier and crazier, they impair your immune system. So again, that's the impact of those 58 million followers on the anti-vaccine social media sites, and that's, so there's an information war going on, and there's a lot of effort to try to amplify the message, fine-tune the message. The problem is, and I think there's been some good faith efforts to make that happen, and now the Biden administration is putting out a series of public service announcements, as is the WHO, but it's still a message in a bottle in the Atlantic Ocean because of the pervasive nature of the anti-vaccine messages. So we're going to ultimately need some kind of more aggressive countermeasures, and exactly what that is needs to be determined, I think, by creating some interagency task forces at the UN and at the UN level, the United Nations level, and with the Biden group.
I'm kind of wondering how things in France are going to be handled to improve vaccination rates. Is there any commentary there? I mean, since we have our hosts there, any thoughts? Because it's also a problem in Europe, right? There's disinformation as well. So I guess Tom wants to step forward. I was wondering, one thing I was, Houston did a great job with the wastewater management and understanding the spread of variants. I just wondered if there's anything that we learned that could be translated to other cities. Is there any outreach? And we benefit by the access that Houston had to Rice University and Baylor College of Medicine, but I can imagine there in other cities there would similarly be access. So I just wondered if Dr. Hopkins wanted to comment on the translation.
Sure. I think we're really fortunate that we had this great team here, and from Rice, we have the civil and environmental engineering experts, and from Baylor, we have the medical experts. So together, we have a very powerful team. The other thing that was important about our project is that it's led by the health department. In other cities and states across the United States, they're actually residing in public works. And the problem with that is that the health department doesn't understand how to use the data. So they're trying to learn how they take their data from public works and what it means to them. So we were fortunate that we went on the path that we have. And you're right, we have been recognized as the leading authority for cities anyway, in examples of implementation. And we provided a lot of technical assistance through the CDC, through EPA, and then individually to health departments, the state of Washington, health department, Missouri, different places like that. And as we move along with the variants, it may be similar. We are working on new approaches for that. We just, to follow up on some previous comments that you made, is that we've had, in the original tracking of variants, we were ordering specific primer probes and assays to evaluate the presence of individual variants. And then now we're sequencing the whole wastewater samples and identifying what we call indicative mutations that could represent the presence of various variants in the wastewater, following that up with clinical testing. And so I think the way Dr. Peirce looks at it in the city of Houston, who's our public health authority, is that we use the wastewater as a screening tool to kind of find out where the variants are, and we want to continue doing that. But as far as partnering, what's really been helpful for us is, I did describe a little bit in my talk that when we have what we call a breakthrough here, when we see somebody that had a vaccine in our vaccine database, and we see them in our disease surveillance database that they had a positive PCR, then we contact them and ask them for a retest. And then if that retest is positive PCR at that time, then we would sequence it so we can understand who's breaking through in Houston. And I realize that's been done across the world, and Dr. Hotez and other people are keeping track of that. Thank you for that. But we are doing it on our own level here to see, which vaccines, which locations, what kinds of people are having it, just because that's what we do. We track that. But unfortunately, that sounds like a great plan. It's logistically very complicated. We contact trace the people that have breakthroughs, find out how sick they were, try to talk with the health exchange network that we have here to figure out how sick they were when they had the breakthrough. But unfortunately, the people that we contact, even though we get them within like a week of us finding out that they've had a breakthrough, are all negative. I mean, I think that's actually good news for the people, because that means that, they're doing better. But they no longer have a positive PCR. We aren't going to analyze that PCR. And so we can't do the variants. So one thing that we could do to understand it better is to be able to go back into the history and get that original nasal swab and sequence that, or have access to more of the sequencing data that's being done around.
No, but it's not identifiable, is it? I mean, isn't that the problem? You can't really connect people.
No, I mean, I'm saying, you mean when we go back and ask, yeah, like, we have this case, can you tell us? We're getting it, but not from Quest or LabCorp. Some of the big companies won't provide us that sequencing data by individual. So I think that would help. But
it seems this approach is very novel. And once we knock down the virus, so it's not as prevalent in the that going back to individuals and contact tracing could be really helpful to stemming the spread, right? So it sounds really great. But anyway,
that's the plan. Yeah,
that's good. There were a couple of questions for Dr. Vorch. There was a question about, could you explain a little bit more about why limited biodiversity helps or is correlated with higher risk of, the zoonotic being able to cross over into human populations and cause pandemics. Could you explain that a little bit better if you're still here? We're here, but I'm not seeing her. You had to leave. All right, sorry about that. And then Dr. Beech, do you have any other comments about challenges and strategies to increase vaccination in the youth? They're also not buying into this very much.
Yeah, there's some interesting strategies being used across the country. In fact, West Virginia was giving out savings bonds, U.S. savings bonds. In the state of Ohio, they're actually having a $1 million lottery per week for people that are entered that get vaccinated, and college tuition provided for students. So there are a lot of strategies. Local watering holes are giving away free drinks. I mean, there's a lot of incentives that are being utilized for this group. And so I think generational approaches, as well as sort of a one-on-one rather than the large-scale vaccination campaigns that we've used heretofore, is just what we're going to have to do moving forward. The vaccine should really be the incentive itself. One would hope that we wouldn't have to provide additional incentives, but that seems to be working in other places. So that's where we're going with the 18 to 45-year-olds, trying to get them vaccinated. And I think the early messages showing that either asymptomatic or very low risk for COVID-19, coupled with later stages of vaccine rollout, which were entirely appropriate, have both led to folks feeling like they don't need to be vaccinated. And again, Dr. Hotez was very eloquent in describing a lot of those reasons.
I think part of it also, I totally agree, is that, I think the narrative that's out there is that younger people don't need it, that this is a disease exclusively of older Americans. They're the ones who are getting sick in the hospital, and that if you're young and healthy and fit and take care of yourself and go to the gym, you don't need to get vaccinated. And the message that I really push hard on is, and so the other part of the narrative is, therefore, the only reason young people are getting vaccinated is to protect older people. And a lot of this comes out of all the Great Barrington nonsense and all of these other conservative groups. And the important message, I think, is that there are reasons beyond altruism to get vaccinated. And we are seeing, especially with the B117 variant, a lot of young people get sick, go to the hospital, and that this is not taking care of yourself is well and fine, but it's not a substitute for virus neutralizing antibody. So I think we need to do a better job highlighting the disease burden in young people and get away from this. That's just death. There are things beyond death why we need to vaccinate young people. Going to the hospital in the ICU is a scary thing. Long haul COVID or persistent COVID among young people is quite serious and quite severe and very debilitating. And I think that would be, if we're going to try to amplify any message, I think that's one that really needs.
And that was a question in the chat. Is like, why can't we amplify the concerns about young people becoming long haulers to help to motivate this demographic?
Well, again, you got people with an agenda. What they'll do is they'll put bar graphs by age, and the percentage of mortality, and it is relatively low in young people, but it also the severity of illness, especially of people with underlying conditions, is quite high, and so there are reasons to vaccinate beyond simply death.
Okay. There was a question in the chat box saying that we've worked very hard with education and communication to try and change behavior with respect to COVID-19? And what are your feelings toward mandating vaccinations, i.e. To go to college, to work, stores? And, Methodist has required that. I happen to drive by and see somebody saying that Methodist is violating the Nuremberg Code, which I guess was related to that. But, if we act aggressively, there's going to be pushback. But if we don't act, then we will have a populace that continues to be at risk. So what's the right balance?
The Chronicle for Higher Education has a list of colleges and universities that have mandated vaccinations for students coming back in the fall. Many of those colleges are being sued now as well. These are complicated issues, and we have to remember what we are vaccinating people as emergency use authorizations. So we wonder if that's going to change once we have full authorizations. But it's a complicated issue. It's a very complex issue, and it's just adding to the myriad of concerns about vaccinations. I'd love to hear Dr. Hotez's point of view on this, but a lot of colleges are wrestling with this right now.
I think there are two things about this. One, this whole Nuremberg stuff. Remember, this is coming out of far right-wing ideology, anti-vaccine groups, and unfortunately, the white nationalists have now tagged on to the anti-vaccine movement, and they love their Nazi imagery. So, my inbox every day is flooded with Nazi images, and also it's not just Nuremberg Code. They love showing pictures of hangings at Nuremberg. This is a weapon of intimidation, and they justify it by saying that because the vaccines are released through emergency use authorization rather than approved. I guarantee you, once they're approved, it's not going to make any difference at all. So there's that piece, and a lot of the again, the white, not just the white nationalists, but now mainstream conservative groups built out around this health freedom stuff that started in Texas in 2015. This is when Texans for Vaccine Choice formed a political action committee, an anti-vaccine political action committee, and a similar one out of Oklahoma. And now they've just revved it up. So it's this health freedom, medical freedom business, and now it's a mainstream part of conservative ideology is vaccine choice, which is really anti-vaccine attitude. So delinking this has become really problematic. Now, one of the things that I've been doing, so I do try to go on conservative talk radio shows and cable news networks. I was going on a lot for a while, then the invitations began to stop. But when I was going on, the first thing they went to was the mandates. There was this, they in some ways they created this straw man that's all they wanted to talk about were vaccine mandates. And I was the first to say, let's not go there yet. Let's try to get people to voluntarily get vaccinated and push that as hard as we can, and really reserve the mandates as a last-ditch effort with a couple of exceptions. And I think one of them are college campuses, and we have precedent for that. So when my youngest son went off to college, he had to prove that he got vaccinated with his meningococcal vaccines, his meningococcal B vaccine and ACWY vaccine. And if you're in a crowded institutional setting, yeah, I think that's very reasonable. And a lot of colleges are now actively saying you've got to be vaccinated. The other one seems to be far tougher than I thought it would be. That, if I go into a hospital, I want to know the person taking care of me is not shedding SARS coronavirus type 2. And I think it's very reasonable to have those mandates. But boy, some of these groups have pushed back really hard on that. Even some of the unions have pushed hard on that. So I think I think hospitals is a very reasonable place, or clinic settings, to mandate vaccinations, but they seem to have drawn a line in the sand on that one. So
well, it seems that you could require KN95 use if you're not vaccinated. That would be one approach. There's some you have a choice. Be uncomfortable and protect people, or be vaccinated.
So Houston Methodist took, I think, a very courageous stance. I'm curious to know how it's going. I haven't heard much about it. And I don't know if other institutions in the Texas Medical Center have followed suit.
There's some discussion about that, but that it has to be evaluated by legal teams, and so that slows everything down. I mean, that is one thing that was good about the pandemic, is that there was a better communication and collaboration among entities, and along those lines, it was great to hear about the ability to put in new bike paths in France and to overcome some obstacles there. I was going to ask one other question about, what about people getting too many vaccines? What about mix and match? And, are those problematic, or any thoughts? Is there a point where, too much of a good thing causes problems for people? Because I could imagine some somewhat obsessive people getting vaccinated over and over again. Any thoughts?
Anybody? Well, I think, and the problem is, I think mixing and matching is certainly warranted if there's limited supplies of one versus the other. This is especially a problem now for people overseas who are coming back to the US and all they got were one of the inactivated Chinese vaccines, or the Russian vaccine, or a first dose of AstraZeneca, and they want to get the Pfizer, BioNTech, or Moderna vaccine. And the answer is we have no data one way or the other, either for safety or efficacy. Intuitively, it makes sense, but there's not supporting data, and hopefully we'll get more of that soon.
Okay. Any other questions from?
I know in the UK this has been more sort of kind of institutionalized, and they practice it more regularly. I'm surprised that there's no data coming out yet. I would have thought there would be. Maybe there isn't. I've missed it.
At least there would be some information about titers for, I think there is a trial right now we have at Baylor where they're trying different vaccines in people to see what the titer levels are like. So it's coming, but, this is where data science can be quite useful. If you can harness information from large populations. It was refreshing to hear Dr. Domenici's talk, in part because it gave insights, but it also allowed us to look at how large-scale data could be disaggregated to give sort of geospatial information about risks. And I thought that was quite useful. It's too bad she can't be here. What about further educating the politicians to be more responsive? How do we do that? That this is a huge challenge, right? Because there's a lot of spin and it's not always positive. But any thoughts from the panelists? I know, Peter, you've been very involved in that, and it's frustrating, but any thoughts?
Well, I think down in this part of the country, the South, where vaccination rates are so low, and for COVID, we do need more leadership. Unfortunately, we have a lot of governors now filing executive orders, no mandates, and we have state legislatures filing no mandates. And the problem, and I understand the mandates, but it's not accompanied by pro-vaccine messages. The subliminal message is watch out for those vaccines, and that is contributing to this as well. So we've got a real problem, because I worry we're going to head to two COVID nations where the Northeast and it's going to look like flyover nation. The East Coast and the West Coast will be well vaccinated, and significant sections of the country in between, especially in the South and in Wyoming, Idaho, will be largely unvaccinated. And then if you remember last summer, we saw that big surge of COVID-19 in the South, and I worry we could see something resembling, and it won't be as bad because some people will be vaccinated or infected and recovered. There could be enough of a blip that this can encourage variants from emerging, and it's going to just prevent us from getting where we want to be as a country.
And so what do we do to avoid this in the future? this is one pandemic. We could have another one. It could happen at any time. So are there lessons learned here? Any thoughts? I mean, monitoring the viral origin of new zoonotics is going to be quite challenging, I think. But would that be possible? Can you start, sequencing back colonies? Or any other thoughts? I think the wastewater management and sequencing seemed like a good approach, but also that's not necessarily scalable. But any thoughts about avoidance? Anyone on the panel? We lost our French contingent, so they could have responded, but in their absence, I guess, Peter, you're the person to ask.
Well, I think, there's, it's multifaceted, of course, but, and one of the things I will say, it's not like we don't learn things after each pandemic, right? After 2002 with SARS, we put in IHR 2005, the International Health Regulations. After pandemic flu, H1N1, we put in the Global Health Security Agenda. After Ebola in 2014, they began meeting at Davos to create CEPI, the Coalition for Epidemic Preparedness Innovation. So things have moved. I think this one will yet again require expanded infrastructure around, first of all, rapid acceleration of vaccines. I think a key change will be recognizing that just relying on the multinational pharmaceutical companies is not adequate for equity. We're going to need to put an infrastructure for developing vaccines across the world's low and middle income countries. Right now, no vaccines are made in the continent of Africa. Very little is happening in Latin America outside of Brazil, maybe Cuba. And the Middle East underachieves in terms of developing vaccines, so putting that infrastructure. I think the other piece that's needed is there's going to have to be recognition that this anti-vaccine, anti-science empire needs to be managed better, and looking at some kind of UN interagency task force to get educated what the levers are, because I don't think we know from the health sector, we clearly don't know what we're doing. So talking to people who go up against cyber attacks or global terrorism or nuclear proliferation, we need those kinds of conversations to understand what are the possibilities and recognize that there are things that we potentially can do.
There was one comment that vaccine hesitancy might be tied to the severity, and because this, in some ways wasn't that severe compared to, say, the original SARS, with a more lethal disease, there would probably be less vaccine hesitancy, but that's a comment.
Well, you had this Janus face of the SARS coronavirus too. You had, one group of people going into ICUs and another group of people that were going to bars and concerts, and that's what made this so problematic, right? I mean, if you had SARS-1, you were sick, you weren't going anywhere, and that's right. It's same with even Ebola, right? I mean,
right.
There was never going to be an Ebola epidemic in Dallas with that one index case,
right?
But
right.
With this one, this was really the virus from hell because of that Janus face, yeah.
Right. So thanks everybody for the panel discussion, and now Dr. Signorak is going to close our symposium. Thank you.
Thank you, Chris. Thank you all. I would like to thank all the speakers for their interesting and inspiring talks, and the audience for an interactive symposium. So let me thank also my collaborators at the Baylor College of Medicine, the Gulf Coast Center for Precision Environmental Health, GC-CPEH, Ariane, Keys, Christina, Cassie, Ellen, and Chris, of course, the Texas Community Engagement Alliance, Seal, Philippe Aretz from the Inserm, and Judith Pameler, NRA, both from Washington, D.C. So we all know that COVID-19 is a complex problem, and we just listened to a few of its many facets: air pollution, traffic, sewage, vaccines, just to name a few. Now I'll try to provide a synthesis of this 5-hour symposium. So it's just one synthesis out of many possibilities. So regarding the bottlenecks, I will see two kind of topics: data for research, where it was said that there was a lack of centralized database of COVID-19 data at the county level and below, even if the data exists. And also the concerns about how good is the data, which variables, and how to be confident, and the need for replication. So that was the first topic. The second is beyond medical and research settings. We just mentioned during the Q&A session about disinformation campaigns, political issues, projects that were there but taking dust and that are now revisited. For instance, public trust that may be low in with regard to health organizations, CDC, NIH, WHO, you name it. And so that will be for the bottlenecks. In terms of trends, I could see more data science. And thinking about our first talk, this sequence, data to data science, to evidence, to policy change. And in that case, leading to cleaner air. I think it was a nice sequence. We'll try to use it. Quality of the data and tools is improving. She was mentioning AI, for instance, but also a related drawback is the identification or disentangling the data to make sense out of it. It will still be challenging. Another point in terms of trends, so education and communications to a diverse and different types of people. So this remains a challenge, but there is also a trend where scientists are actually more interacting with people outside from laboratories, universities. And let's keep in mind that even if better policies are implemented, we need to pay more attention to low SES communities. They already have cardiovascular disease or higher frequencies of cardiovascular disease, diabetes, and so on. And so moving to a personalized prevention would be probably an interesting path for the future. In terms of prevention, that will be the last part of this trends. So we were reminded of the strong history of shared diseases with domestic animals, and also the increasing numbers of zoonotic disease in the 21st century. And it was advised to stop spillover, so to make prevention occur before spillover. So these are a few thoughts that were ideas that were emerging during these talks and presentations. And on our daily lives, we need to be focused, but at the same time, we also need to be open to what is happening, right, in other fields. For instance, to assess new or underscored variables. So even if we touch the topics of sewage, traffic, air pollution, vaccines, etc., let me also mention briefly a paper that was published in Science a few days ago, entitled "The Paradigm Shift to Combat Indoor Respiratory Infection." And this could be interesting as it does not require a shot in your arms. And we were discussing how difficult it is. This is definitely a less invasive means to move forward. So Lydia Moroska and her colleagues point out that, in fact, a large amount of legislation and investment were devoted to water quality and food. By contrast, airborne pathogens and respiratory infections, whether seasonal influenza or COVID-19, are addressed fairly weakly, according to her, in terms of regulations, standards, and also building designs and operation pertaining to the air we breathe. So in this article, they highlight a key engineering measure that would be ventilation supported by air filtration and air disinfection. So as Louis Pasteur said, so we all know that he was really involved and discovered a few principles of vaccination. He said, chance favors the prepared mind, so let's be or remain prepared. To conclude, do not hesitate to contact and interact with our speakers, knowing that this symposium contributed to spark collaborations will be wonderful. Let me wish you a pleasant evening if you're in France and a nice day if you're in the US. Bye-bye, and thank you.